Good afternoon, and thank you, Tane. I need some of that energy around this conversation. Thank you so much for being here. It is my privilege to be in this conversation. Today I'm wearing two hats. One is the role that Tane described. I am the new president and CEO at the St. Paul and Minnesota Foundation. I also sit on Allina's board. Oh, so it gives me just a unique opportunity to look at sort of the intersection of health equity and wellness across the state and how these pieces must come together for us to create a more resilient and healthy community and healthcare system across our state. It is way more complicated, way more complex than I ever understood until I got around the table. And so today's conversation is just a little attempt to bring some new knowledge, hopefully, to you about what we're facing in healthcare. So, Lisa, thank you for agreeing to spend your Saturday with me.
Oh, my pleasure.
Awesome. So we are going to jump right in and talk about the unique challenges of healthcare, what is happening locally and nationally that we need to understand. And what I can say is watching you, Lisa, through some really complicated systems, right? I'm entering into a new role and learning everything, and the amount of things that you have to know in healthcare is pretty incredible, and you seem to have it down pat. And I watch you do that with ease and joy. And so I guess I'm just going to start out with a little bit of a question around joy. Is sort of how are you keeping yourself sort of grounded in the middle of a lot of complexity and uncertainty?
Yeah, well, thank you. And when your boss, one of your board members says, do you want to come hang with me on a Saturday? There's only one answer. And I'm thrilled to be here. I love talking about healthcare. I've spent my whole career in healthcare, as you know, and started clinically as a dietitian and been in leadership for most of it. It is not hard to find joy in healthcare. What we get to do for all of you, for my family, for me, is make people well and prevent disease. And there is a lot of joy in that. I'd say the people do often ask against a really challenging, I'm not naive or Pollyannish, about the really big challenges that we're facing. We faced them for a long time, but it's really coming to a big head right now. What is the one thing I do that most gives me the energy? And it's what I did on Wednesday and where I was on Monday, which is when I get to spend some time with our care team, with our nurses, with our doctors, with our ancillary team members, and see what they do and the benefits they provide for our patients. It's energizing every time.
When I think about healthcare, I think a little bit like I do with education, where we have all been through the system at some point and we have an opinion on it. And so when we're looking at what is in the news, often our lens is more towards a personal health perspective. How should we be thinking about what's happening in healthcare right now?
Yeah, I think that's a really good question. So I want to amplify what you said. So I've been in healthcare my whole career. Most of us in healthcare have. We train technically, clinically, or we're in leadership roles. And we get the great privilege of leading services that the people we love most during their most vulnerable times receive. I can't think of a better thing that you could be more committed to. It is really complicated right now. So we talk a lot. I talk with my team a lot about two things that are completely opposite are happening at the exact same time, and we have to hold them in each hand. So on one hand, I know we're going to talk more about this, it's the most exciting, innovative, curative time in medicine. On the other hand, it's the most vulnerable, frightening, and worrisome time from a business model and economic and coverage perspective. And so as we navigate these two opposites that are true at the same time, we have to do that with what's top of mind, and that's what does our community need from us? What are we really good at? And how do we create a sustainable future? Because a lot of us aren't currently in a sustainable position.
Yeah, so what is happening in Minnesota? Like, we're seeing a lot of movement and concern and financial challenges, and you know, if I had my personal hat on, I would say I'm paying a lot of money for healthcare, but it is not showing up in the bottom line, apparently. What is happening?
So maybe if it's okay, I might start nationally what's
Yeah,
happening.
please.
So we are facing breakthrough innovations that cost a lot of money, whether it's new drug therapies for weight loss, whether it be new therapies for technology and equipment, rising labor costs in healthcare coming out of the pandemic, the public health infrastructure in most of our communities was already challenged, and boy, it really frayed. Then you look at that combined with the economic challenges that healthcare's been facing. And when I say healthcare, let me define it. So healthcare, of course, includes insurance companies, pharmacies, medical devices. When I'm talking about it, I'm talking about hospitals and health systems and doctors and clinics and what we do in home and all the things that are direct patient care. And those direct patient care areas for my whole career, government reimbursement has not paid for the cost of the care. And therefore, we shift the cost of care to commercial payment. And that then causes an imbalance. And when the cost of the care isn't covered and the government the percent of government pay is increasing, you get a math problem of epic proportions. And here in Minnesota, we're a bit worse off than some other states. And part of that is we lack some reimbursement programs that other states have, and it's technical, I won't get into all the details of it, but we also have an environment where our community in the country, about 11,000 people are aging into Medicare every day. Here in Minnesota, as a percent of that total, we're aging a little bit faster. And so that is creating some extra pressures for not only the hospitals, but we are also seeing some of those pressures for some, especially our nonprofit payer colleagues as well.
What do you think is most at risk right now?
So let me talk about what I believe. So I believe that healthcare is a human right. I really believe that. I believe education is, I believe healthcare is. And I've spent my whole career really working to provide access to care regardless of an ability to pay for that care. When I think about what most of my colleagues, and I have the opportunity, real privileged to serve on a national organization that represents 5,000 hospitals and health systems in our country, most of us are fighting for our lives to keep care available. And the care that is most vulnerable is the care that requires subsidy from us. And that's a lot of it. It's in primary care, it's in mental health, it's in obstetrics, it's in a whole host of services. It's most of the medicine versus the procedural areas based upon the economic model that exists in our country right now. And so when we talk a lot about when the OBBA was passed and signed in July, that's creating huge risk for, it's taking $1 trillion out of healthcare. And people are really worried about rural healthcare, me too, and it's not just rural healthcare. A lot of our Medicaid recipients are in the metro. They're in the cities, so it's a both and. And when I think about what I'm thinking all the time, it's how do we keep our services available for the community and be smart about choices. We're gonna have to restrict in certain areas of our community. We don't have a choice. If we don't make those kind of decisions, the whole will be harmed. And so we're really in deep thought and planning to do just that.
Yeah, we'll get to innovation in a second. I do know, and I'm thinking now about a particular community that maybe has some vulnerabilities, those with mental health issues. And so we have the lack of infrastructure on one side, and I know that they're showing up, folks that are struggling, and their families are coming to emergency rooms. And so when you're talking about vulnerability, can you just walk us through that one particular segment of our residents
Yeah.
and what that looks like?
Yeah, for sure. So there's only one clinical door in our community that's always open, 24 hours a day. We never close, and it's our ERs. And so in our communities, individuals who are in crisis, as we know, are in increased percentages, they are entering the EDs. And we're doing our very best to provide the care that they need, and we have exceptional care. I'm really, really proud at Allina Health and all my colleagues around the community. That said, sometimes people end up in our ERs because they don't know what to do. We've had family members drop off children who are neurodiverse because they're at their wits' end and they don't know what else to do. And those patients, as they enter our hospitals, aren't necessarily there for medical care. They're there for social and support services. And if you've ever been in a hospital, we do our best, but we're a little noisy. We got a lot of bells, we got a lot of things dinging, we have a lot of lights, we have a lot of people. And if you're on the spectrum or you have neurodifferences, that's not the most soothing place for you to be. And so if you hear nothing else, we have to have a partnership with community, with our hospital systems, with our government, with philanthropy, which you're deeply involved in. So mental health care is something we do a lot of, and it's clinical. There are a lot of clinical ways that we can treat mental health. Many of what enters our hospitals, though, go beyond medical need. There are behavioral or other issues that families are really struggling with.
Yeah, and so, we're talking about sort of an ecosystem of care here, a little beyond Allina's scope. And if I were just to play that all the way through, though caring for those patients are not reimbursable.
Correct.
That's correct. And you have a duty to care. How many populations of people does that run? Like, what is a percentage of patients? Could you respond to that in terms of reimbursement?
Maybe I'll give a couple examples. So we have individuals who are behavioral or neurodivergent that come into our facilities, and we could have in any given day, 20, 30, up to 100 of those patients. We also, post-pandemic, had individuals in our hospitals that were ready to go home or ready to go back to their original site of care, and that was a nursing home or a skilled nursing facility. At the peak of that, we were essentially housing, I mean that respectfully, housing patients who were no longer needing medical care in the tune of about 120 of them a day throughout the Allina Health system. Imagine, that's a very large community hospital without reimbursement that our amazing and skilled nurses and doctors are taking care of, but there's no payment for those. So it's a real strain in the system. We've worked really hard to collaborate with our facilities and partners and community to reduce that, and yet we face it every day, and it's a privilege to be open every day around the clock. We never close, we're always there, and it's an outsized responsibility when the economics are challenged. It creates great vulnerability.
For this particular issue, is there maybe one thing that you would want the audience to maybe understand or take away about this issue?
Yeah, we need a lot of partnerships and a lot of collaborations. We need all of us thinking about what are different, new, innovative ways to serve these patients and particularly these families that are trying to wrap around services. We think we're a part of the solution. We just can't be the only solution.
When I sit in the boardroom and had the opportunity to tour some of the Allina sites, I often think about the challenge that we just raised, where you have costs associated with services that aren't reimbursed, and it's creating a financial burden. But it is a system that is dependent on innovation and advancement to save our lives. That is a real tension. And I want to just spend time. So now we understand this piece, but let's talk about the innovations. What are you the most excited about there?
Yeah, thank God we got to this. This is the part I've been waiting for. There are hard things, and again, we have to navigate them. This is a time of medicine like none other. I am, and you hear me, I am super excited about what's happening in medicine. The things that my parents, who both passed in my tenure at Allina Health, suffered from at the end of their life, the things that their parents suffered from, my children and grandchildren may not, because of the innovations that are coming in. Give you a couple examples. So we now have at every single CT scanner throughout all of Allina Health and our partner hospitals, advanced analytics that are supporting AI, that are supporting our physicians to detect a stroke. And let me tell you what that looks like. That looks like an 18-year-old who passed out, who families worried about, why did they faint, brought into one of our ambulatory ERs, got a CT scan, and what used to take 2 hours took 6 minutes. And in 6 minutes, that child, that young woman, was having a massive brain bleed, was having a stroke. We transferred that child to our Abbott Northwestern. They walked out of the ED. We were able to eliminate that blood clot. And that young woman was the daughter of one of my doctors. These are the kinds of things that we're getting to do because of new technology. We now have only one in the Twin Cities, incisionless brain surgery. Yep, that's what I said, incisionless. It is a focused ultrasound procedure that is an outpatient. You can come in. It is curing Parkinson's and non-essential tremors, people who have struggled their whole life. And we have well north of 100 people on a wait list right now. That was never possible. I saw technology on Monday. Essentially, I'll spare you all the technical names. It essentially was an ablation of solid tumors in liver. Instead of a massive liver surgery to remove a tumor, we may be able, with this very focused ultrasound, to essentially burn and ablate the tumor. It's an exciting, exciting time. I mean, we are discovering, despite our challenges, we're really discovering things that were just never possible before, and it's accelerating now. We have to find a path to fund it.
Yeah, is there anything that we need to take away around our focus and support of innovation in healthcare?
Yeah, we need science to be really, really strong in our country. So thank you all for standing with science. We need, I'm going to make a plea. I need our doctors and our nurses to know you believe them, you trust them, you bring your questions, your smart questions to them. And in that spirit of innovation and support, always ask, always push us, always explore if there are alternatives. But as you think about what we're trying to do in community with and for everyone, let's see if we can't find a way to, first thing is, how do we prevent disease? That's always best. How do we detect it early? That's better. Because when we delay care, and sometimes that's related to coverage, people can't afford it, we see what we saw after the pandemic, where we saw disease more profound. So I would just ask all of you, it's the same answer. We have to do this together. No one part of the ecosystem can do it alone.
Mm-hmm. I'm glad that you brought in the team that you work with, and I wonder if you can help us put a perspective on how we should be thinking about the team in AI. Yeah. So I hear some people that think, AI is coming, they're coming to replace people. Should we be concerned about it? AI didn't just show up in healthcare. It's been around for a long time, but we're hearing about it now differently. So how should we be thinking about the team and some of the advancements, particularly related to AI?
I bet every one of you in this room know there's a healthcare shortage. There's a nursing shortage, there's a physician shortage. It's profound, and we haven't seen anything yet. So if AI can help our nurses and our doctors, which I believe it can, work at top of license, we're gonna do a lot better than we would otherwise. Our country does not have enough caregivers. And what we see it, I almost wish it wasn't called artificial, but almost augmented or assistive intelligent, because at the end of the day, it's still gonna take a clinician. We know that we have some of the most amazing radiologists at any place I've ever lived here in Minnesota. They catch the smallest of concerns on advanced imaging procedures. And yet we put in AI for lung cancer screenings, and we picked up 400 more tumors that the naked eye just could not see. Now that required those expert physicians validated. That's catching disease at the earliest possibility. So I see it assisting our care team, and the reality is we do have to drive our costs down. We aren't gonna have enough labor, so the both and should come together.
Very good. Any questions in the audience? Yes.
This one's going to be a little complicated, but it will answer the question. For years and years, we have had our service through the Allina Skyway clinic down on Nicholas Mall. And I know that a number of facilities are being closed now. And I think our closest one,
No, it's on. Just put it.
I think our closest one will be probably Greenway. That's where my physician and others are going. The problem that I'm seeing is that I'm on Medica and my partner's on UCare. And Medica's, according to the Commerce Department, is going up by 27%, which is $115 a month. And then my partner's is going to lose the subsidy because of the big, beautiful bill, or whatever it's called. And so we're gonna be hit with another couple $100 a month in terms of costs. But what is happening as a result of moving out of the Allina clinic is that a chiropodist is going to be in Edina, our physician's going to be at Greenway, my physical therapist, because I'm having trouble with my right arm, is going to be in Plymouth. And what we're ending up with is a lot of, how should we say, long-term commuting, essentially. And so luckily we have a couple of cars, so we're able to do it. My partner will go with me and so on. But that's what I'm seeing is we're paying more and getting a lot more fragmentation, and I just wonder if it's possible to pull some of that together.
Yeah, thank you. First, thank you for being a patient of ours. And what I would say is what you're referring, in case everyone in the audience doesn't know, we made the difficult decision of consolidating some of our clinics. We have the backdrop is about 300 exam rooms throughout all 100 plus of our sites that were not well utilized. And as we try to serve the community and keep services available, and as more care is becoming available in the home and available virtually for our patients, either through virtual care or even home care, we just found that we had to make those changes. What I would hope that you would experience is not fragmentation, but instead integration, and yet it will be at different sites of care, but through both our electronic health record and through how the care teams are working together. My hope for you, and certainly I'm happy to have conversation afterwards to see if there's additional support we can provide to ensure that that which we can do virtually and in the home to save a patient a trip, we always want to do. And many of our physicians are engaging in that, frankly, quite meaningfully. And then that which is needed in a separate location it should be digitally and technically quite connected for seamless care. It doesn't mean we're perfect and there aren't gaps, so I'd welcome hearing more about if you've had any of that experience.
Wally kind of sparked this question. So what should we anticipate as we've seen legislation changing eligibility for the exchanges, changes in Medicaid eligibility? What's going to happen? What do you? How are you all preparing for that? Do you expect more uncompensated care? What does that mean for everybody else who has insurance? Interest rate? Premiums and rates. What do you think?
Yeah, I think it's going to be really hard, AG. I think when you look at what's going to happen, as a country, we're taking $1 trillion out of healthcare. We are backfilling that with $50 billion. So thank you, but backfilling it throughout our country. And here in Minnesota, what I'm deeply concerned about, and had this conversation, in fact, on Monday with the governors and the governor himself, is we have 87 counties, 11 tribal nations. They all have to individually create processes for work rule determination. That's not a hospital job. We absolutely want to help patients navigate. We're there to provide their care. Their work rules will have to be eligibility determined ahead of time. And what we're going to find is a lot of people are going to lose coverage and they're going to be confused by it. And we're going to do our very best to help transparently share and direct them to places for their support. And yet that's where we really need the state of Minnesota to have a common platform for consistent work rule eligibility that is the least confusing as it can be during a really confusing time for patients who may have other vulnerabilities that make it difficult to understand those processes. So I am deeply concerned, really deeply concerned about what will happen if you don't have coverage and you don't get care. You'll end up in the ED instead of really treatable. Stage 1, you're going to be an all-out, more significant. So we are looking at, on a positive side, partnering with community organizations. We're looking to partner collaboratively, of course, with the state, as we have great relationships and want to be part of the solution, and to partner collaboratively with other healthcare in the community, which I think we do a great job as a community. I would also say I think some of our ideas and solutions are going to come from outside of Minnesota as well. So we're looking for partners. This is a national problem, not just a Minnesota problem. And Minnesotans are smart and awesome and all those things. And we're going to look for answers outside of Minnesota to help us as well. Yeah.
Yeah, I can't believe how time flies. We are at time. I see one hand. We will take your question. Just know we're at time. And I will walk this mic over to you.
Thank you. Just so you know where I'm coming from, we've been patients in the Allina system for 25 years, since we lived in Minnesota, actually, and it's been very good medical care, okay? Very briefly, we came from Canada. I was a litigation lawyer there, ruthless private enterprise. Came here when the Wild started. I was the assistant general manager there for 11 years, then with the New York Rangers. All private enterprise. But I've traveled, and I think I've taken people to hospitals in 11 different countries, and I have the Canadian background. We are paying way more than any other country in the world for our medical care with far less coverage. Ma'am, you're speaking very articulately, and you seem to really care about things. Can this system work when you're going to have the baby boomers going into their seniors' age, like I am now? I think we all have to take a deep look at this thing. When my father's terminally ill in Canada, I forgot my thyroid, my levothyroxine pills. Not going to make a big deal of it. I go there, pay the full amount, and the full amount is less than my copay here. I say there's something wrong on that. The innovation on these matters, even on the COVID vaccines, 3 of the major 4 came from countries outside the U.S. So it's not like we're monopolizing the developments. My big question is, and I'm an optimist, do we have to change the system so we've got a national consensus on things? And as I say, this isn't a radical left-wing view. This is what all the other countries are doing. And I think this would support the basis for a business-oriented country.
Yeah, Tommy, thank you. There's nothing left to say other than you are spot on. The business model in healthcare in our country is not working. It's not working the way we need it to, and we have to change it systemically. If we believe that, you know, the fix that we just put in place is going to be sufficient, unfortunately, all the other incentives and business structures in healthcare, all the other players, because there are a lot of players that participate in the healthcare dollar, and that's not our country system. We spend a lot of time nationally studying that. We have a systemic structural challenge, and I'm with you in it, and I hear you. Thank you. Yeah. Perhaps, yeah. Yeah, very fair. Thank you. Thank you.
So obviously, this conversation could go on, and we're just getting started. They gave us a short time to be here today. I'm sorry. Yeah, so they just gave us a short time, but I think the invitation here is that we all have to think very deeply around what is happening around our healthcare system. We need it to work for us. It is deeply personal. I appreciate and hear your points that you raised. They're good points to raise, and they're things that we are certainly sitting on at the Allina Health System and on the board, really thinking through what does the future look like, where care can still be accessible, and what everyone needs when and where they need it. Did I get it right?
You got it. All right, thank you,
All
everyone.
right, thank you so much.